of respetamos muchos a los Pumas por su valor y talento. I was a rugby player. So embolization for fibroids is a very interesting way of treatment because fibroids are very frequent, around 50% of women. And when there is symptom, you can treat as bleeding, pelvic pressure, pain, but also infertility. That's a very good topic. You have different treatment for fibroid, but the best are myomectomy or embolization because they treat the fibroid and they retain the uterus. So I start doing embolization now for 25 years, and I perform every years around 200 fibroid embolization. So it's a really good topic, and it's really appreciated by the women. I did also a paper in the American Journal, you'll see later, about embolization, fibroid, and fertility. So, as you showed before, to perform embolization is not really difficult. It's quite easy. The most important is to do, but to understand what's happened. So, the main, that's the most important, that if you can see there, you have one big fibroid, you have the uterine and the ovarian, and all the vessels are very small. The number of vessels are very small, but the vessels feeding the fibroid are really big. So when you are in the good positions, you can inject small particle just to block the vessel of the feeding vessel of the fibroid. And I'm working always in 4 French. So it's a one-night patient hospitalization. So that's what's quite wonderful with uterine embolization. If it's that you can embolize all the fibroid. And that's, for me, the first goal. You don't treat one fibroid or 2, like with myomectomy, because it's quite difficult. In one session, what's around 30 minutes, you can treat all the fibroid. Like you see on the left, there is two fibroid, but here there's maybe around 6 or 7 fibroid, and this one more, sometime until 20 fibroid. So the technique is quite always the same, but for each patient, it's always also some details and some difference. The most important is to have a good team with anesthesia, to have a good sedation, to be in the right place, but you show us before, and just to inject in a free flow, and also to take particles over than 500 micron. I use Embosphere from Merit Society. I always start with the red one. It's 500 to 700 micron, and then the green one, 700 to 900. Okay, we have always to take care of the retro feeding artery for the ovaries. So that's an embolization. You are in the right place, in the horizontal segment of the artery. You see the vascularization of the fibroid, and slowly you inject microparticles just to block all the vessel. And at the end, you have no flow in the fibroid, and you see an anastomosis to the ovaries, and you see other vessels. That's the good moment just to stop and not to do too much. Around in half of the patient, you have the uterine artery feeding the ovaries, but you have also a retro vessel from the uterine artery. And when this vessel is at a big size, you can do untargeted embolization. So we take a micro catheter and put a microcoils just to protect the ovarian. And after, when you put the micro particle, they go straight to the fibroid, and you have no risk with the ovary. That's an example, before embolization, you see a big fibroid, and you see also the anastomosis. So with a micro catheter, you put a microcoil, and then you can start the embolization just to have the best result and protect the ovarians. So it's very important before embolization just to do MRI. MRI helps you just to plan the embolization. How many fibroid, what kind, the size, and very often you can find also adenomyosis that you also can embolize. It's a little difference, I explain you later. And also you are sure that you have no concern or nothing, no contraindication. What are the contraindications for embolization? For me, of course, when the patient have no symptom, there is no sense to cure them. And also when myomectomy is quite easy when you have a subserosal fibroid or a submucosal fibroid with a good size. It's very interesting for women to keep their uterus and to avoid hysterectomia for fertility, for the pelvic, for pleasure, and for a lot of things. And the success, you'll see later, it's around 80% with risk very, very low. For me, just close 0. There is no risk to do the embolization, but we have one thing is very important. It's just to take care of pain because it's really painful for the 6 or 8 hours after embolization. And one other interest, then you can cure a woman with a problem, with like a coagulation problem, overweight, and things like that. It's a very soft technique. When myomectomy is not possible, we can perform embolization. That's 2 cases of easy myomectomy. That's a subserosal fibroid. They can cut like this. It's quite easy. This one is a submucosal fibroid, also easy for the surgeons. When I started a long time ago, we were very, 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 very prudent. But now, with the time, we can cure quite every fibroid. Like this one, you can imagine, she's 30 years old, she has no child, and have this transmural fibroid. If the surgeons perform myomectomy, it's really dangerous to have connection between the cavity and the serosal. So that's a good case for embolization. And some example, a very young woman, black woman, with a very huge fibroid, with a distortions and the compression of the uterine, and also pressure on the bladder. And 1 year after embolization, you can see now quite a normal uterus. You can see the cavity, and there is a scare, but that was a good healing. And this woman is asymptomatic, and she can expect to have a child. When the fibroids are inside the cavity or transmural, very often, after embolization, after some months, there is nothing, and the cavity is quite normal without any rest of fibroid. Sometimes you have expulsions, and expulsion of very huge fibroid. That could happen. So now today, the indications for embolization for me are very, very wide. You can cure a lot of big fibroid. You can cure, I think, if you talk with gynecologists, a lot of patients. Even a 53 years old patient, we had anemia and bleeding because she take aspirin, and you see the huge uterus on the size. You perform embolization, and she stopped bleeding on the next day, and the healing during on 1 year, but 5 months later, all the fibroid were necrosis, no blood inside, and the size was really low. So sometimes you have very complex cases. These old women have menorrhagia and dysmenorrhea, but she has also a lot of miscarriage because she has a lot of fibroid inside, and the gynecologist, they couldn't do nothing. So we decided to perform embolization. It was in 2007, and the embolization was easy, with no anastomosis with the ovaries, and the follow-up was quite easy. And the fibroid, the necrosis, and after with a simple myomectomy, the uterus become normal, and she had 2 children later. So embolization on fertility was a really big polemic, because there were a study a long time ago, not a very very serious study, but it was a very good bashing for embolization. So I do a paper in the American Journal of Obstetrics, and we had more than 109 births after embolization, and we can understand what we did and what we treat. You know, we treat this transmural myoma, all kind of fibroid that the surgeon couldn't remove by myomectomy. And also we treat adenomyosis with quite a big size of fibroid and a number of fibroid around 4.5. And we had a lot of data about what we did. So there is a clinical success around 92%, and in 1 woman on 3, there was a total adenogram restoration of the uterus after embolization and after healing at 1 year. So we had normal pregnancy with normal child, and we can conclude for potential predictors. So we know what the clinical success rate in function of what we treat. You know, with the polymyomatosis, we have % of success. Adenomyosis is quite difficult, we'll see later. And we have predictive factor for clinical success. But most important, we have predictive factor for pregnancy. So we had a lot of pregnancy with transmural, subserosal, polymyomatosis, but with submucosal and adenomyosis, it was really lower. So maybe we can do better, and I have some idea, and we can talk about it. Ovarian protection is also a good predictive factor, like restoration of a uterine cavity who is compatible with pregnancy. Also, adenomyosis is a good challenge for embolization. I think that maybe 10 years ago we didn't know how to do, but now I think we find the good way of embolization, because you have the medical treatment. It's good for 1 year and 1.5 years, but after, and very quickly, the women went to hysterectomy. So it's possible to perform embolization, and there was a study that showed 75% of good results, but I think now it's better, and there is two studies with better results we are coming. Embolization for adenomyosis is a little different because the vessels are really smaller. This woman, I have to protect the ovaries with 2 microcoils, and after you can inject microparticles. For adenomyosis, I use 500 micron particle, very smaller, but we have to be careful. But the result is really good. As you can see later, that was a big adenomyoma, and 1 year later, you have a little scare, but it will be better after. And this is really unbelievable, because you have adenomyosis like this. You have no really one target. You perform embolization, and 3 months later, all the adenomyosis is necrosis and going to heal in the next year. That also with this, with the thickening of the junction zone, and 3 months later, everything was good. And the other indications are really rare, like malformation, fistula, and like you can see. That's very important to have good relationship with the gynecologist, with the anesthetist, and to talk with everyone to choose your good patient for embolization. Thank you very much.